Afternoon. My name is Robert Rothstein, and I'm a neuro-ophthalmologist and glaucoma specialist. And I practice in Queens, New York. And in the practice, we have a multitude of patients with diseases of neuro-ophthalmological diseases and glaucoma diseases. And additionally, we also see comprehensive patients with that need comprehensive eye exams. I want to speak today about the Optovue Solix and its and why the Optovue Solix. What makes it a unique device, and what makes it differentiates it from anything else, and how it has really impacted my practice of ophthalmology. And I will be discussing case studies and some of my insights into this, with using this device. So the question is, why the Solix? Why the Optovue Solix? And essentially, the Optovue Solix is a multimodal device. That's really in a nutshell. It can basically image the entire eye. The OCT is not just an OCT that just images the posterior segment, the retina, and the optic nerve. This can do a whole lot more. It's multifunctional. So we have full range anterior segment capability, the ability to image, evaluate the surface of the cornea, the surface of the lens, the angle, and assess ocular surface disease. We have the ability to evaluate full range retina, which is a much larger scan with higher definition. We also have new scans with new scan patterns that have better reproducibility and repeatability with earlier detection. And the piece of the resistance is exclusive angio analytics. Optovue was actually the first company to have OCTA 3D technology. And it is actually the only device that it was FDA cleared for its metrics. And while outside the United States, other devices do have metrics, it is still the only device that went through the rigorous process of getting through the FDA. And that says a lot in terms of when you actually want to really assess its ability to measure these factors. So what does that mean, multimodal technology? Well, multimodal means the front of the eye. So we have external photography. We have meibomian gland visualization using IR, infrared meibography. And we also have photos that you can take of the cornea, sclera, and conjunctiva that can then correlate with a OCT scan, as you see on this slide. One of the real important features of the Solix is its ability to perform corneal and epithelial thickness mapping. It is able to perform a pachymetry map, is able to perform epithelial thickness map, as well as a stromal thickness map. Now, why is this important? Well, pachymetry, obviously, we all know is important with the diagnosis of glaucoma, as thin cornea is a major risk factor for glaucoma. But it's actually, I find it actually helpful as a cataract surgeon. There have been times where after cataract surgery, uncomplicated cataract surgery, that a patient has had suboptimal vision. And on slit lamp examination, there's no really obvious sign of corneal edema. But when I perform a pachymetry map, I see that there is some subtle edema there, and that can actually explain why the patient is not seeing as well as I think that patient should be seeing. And what's nice about the pachymetry map is you can actually follow it over time, and you can actually see it improve. And in most of my patients, when that is the problem, when the corneal edema resolves on the pachymetry map, so does their decreased visual acuity. It's also useful for any kind of corneal edema that needs to be monitored. Now, epithelial thickness map is really useful in really two cases specifically. It is an excellent tool to screen and diagnose dry eye disease. And once diagnosed, it is a great tool to actually monitor the improvement or progression while on treatment. The epithelial layer gets very thin in dry eye disease, and there are studies that have shown that. And that is actually evident on the epithelial thickness map. This is basically shows two slides. One slide is actually showing the dry eye component. There's another thing that the Solix can do. It can actually measure the size of the tear foam if that's something that someone wants to follow. Now, the epithelial thickness map is actually the best tool to diagnose early keratoconus. It is actually more accurate and will diagnose it more effectively than other technologies such as Scheimpflug imaging. There is a classic pattern that's described by cornea specialists, a donut pattern that one sees, and that has to do with the cone itself and thinning and thickening around that cone, and that's what it sees on the epithelial thickness map. The full range anterior segment imaging is really what makes this device stand out. As you can see, you can see in one scan, you're able to see the entire anterior segment. You can see the sclera, the entire cornea, white to white, and you can see the iris, and you can see the lens itself. With this, you can actually estimate what the angle, the degree of the angle. You can actually find out what the anterior chamber depth is, and if you actually shift the scan to scan more deeply, or shift the depth of the scan, you can actually image the entire lens itself. You can measure lens thickness, and more importantly, you can actually see lens opacifications, which is important for two reasons. Obviously, it's great for documenting visually significant cataracts, but it's really helpful in educating your patients for the need of cataract surgery. Again, I'm reiterating that this is one device that's doing all of this. Again, this is a device that once we thought was only meant for the posterior segment, and now we're really focusing and we're able to see so much in the anterior portion of the eye. But and for those who are refractive surgeons, you can actually look and you can actually evaluate the position of an ICL. Moving to the back of the eye, we have a much larger image of the retina in terms of width and height. We have 16 by 6.25 millimeters, which is really very helpful when wanting to get a much greater length of the retina, and also being able to visualize the vitreous itself. This is especially important in patients who have high myopia. Just to show you what the other devices do, they typically have a 2 to 3 millimeter window. And again, this is the other swept source. I'm sorry. The spatial domain devices. Now the Optovue has OCTA angiography, and it's able to image a 6.4 by 6.4 millimeter to help ensure complete ESCRS data, even when fixation is slightly off. It's able to produce a 9 by 9 and a 12 by 9 millimeter, 9 by 9 millimeter and 12 by 12 millimeter image as well. If one wants, using montage abilities, one can go as large as 16 by 16 millimeters. Optovue angiolytics OCTA metrics are the only FDA cleared metrics, as I said before. And one is able to assess flow area measurements, non-flow area measurements, FAZ metrics, retinal vessel density, and disc vessel density, which is also known as radial peripapillary capillary density. And these are just some examples that are provided that show you the foveal avascular zone in normal and diabetic eyes. You have a normal eye, you have a diabetic eye, and you have more advanced diabetic disease. So this is the actual avascular zone, foveal avascular zone. And you can monitor FAZ change over time. This is obviously with the predecessor of the Solix, the Avanti, which also had OCTA. I'm moving to vessel density. This slide also shows you how vessel density is indicative of the severity of diabetic eye disease, diabetic retinopathy. You can see that as the disease worsens, so does the vessel density. It decreases. And you can actually similarly follow that along over time and see the decrease with as disease increases in severity. Now, let me just speak a little bit about how this data is presented to you. It's presented in a way that your eyes look at it and you pretty much have all the data in one place in different iterations so that one can really assess everything on one page. Now, the Solix does have fundus photo capability, so one could opt to have the photo taken so that one has some reference to the actual fundus photo. And as you can see, as we go down, we actually have the actual B scan of the macula or of the fovea there as well. We have two representations of retinal thickness. One, which is the absolute retinal thickness, and the other, which is the ganglion cell complex thickness. Now, here we have the absolute numbers, but one can actually also, when clicking with the deviation map, you can get ganglion cell thickness. And while here you actually have it's highlighted in terms of what is clinically significant. These are averages, but one can actually get a map as well that shows you the actual thickness in a pixel to pixel normative database map. Below, you see you can actually see the data itself, the numbers, the metrics itself, superficial vessel density, deep vessel density, the foveal avascular zone, and last but not least, retinal thickness, foveal, parafoveal, and in terms and looking for asymmetry. In the middle, we have these en face images that also show angiographic imaging on different layers of the retina, which can also be altered, and one can also see this in 3 dimensions. Now, the optic disc analysis is similar. You have basically 3 views of the optic nerve, giving you 3 different perspectives, pictorially, and then you also have the data in the center. So you have your picture of your optic nerve. You have a pixel map of the normative database right next to it, and below that you have the peripapillary ring, or the optic disc ring, that provides some greater averaging and it's divided into 8. And below that, we have the actual image of the optic nerve capillary bed. And then on the sides, now, just again to point out, just with a little click here, the GCC thickness is the absolute numbers themselves, but with a click of the deviation map, you could actually see a pixel to pixel depiction of loss, ganglion cell complex loss, which is based on the normative database. Now, moving forward downwards, we have further averaging of the RNFL thickness. We have averaging of the superior and inferior hemi portions of the retina, and then also in quartiles. And similarly, we have the same thing done with vessel density. We don't have a normative database with the vessel density, but what we really should be using that for is looking for asymmetry. And of course, when we're doing this in terms of long term, we could also be obviously looking to compare it to previous scans. And finally, we do have the AB scan of the OCT. In the middle, we have, again, different analyses. We have the actual graph of tracing of the optic of the RNFL, and then we have the RNFL analysis, looking at the superior and inferior RNFL. We have optic nerve analysis, which looks at the cup to disc, and we have ganglion cell complex analysis, and finally we have the RBC vessel density. Now, I just want to bring up the fact that Visionix and Optovue, the same company, but they really worked very hard on upgrading the technology. So it's not the same device that they had beforehand. It has, this is just technical data, but some might want to know about it. 120,000 A scans a second. It uses deep learning for improved segmentations of the layers of the retina. It uses infrared tracking, which are 30 frames a second, which is quite fast. It also has a motion-corrected technology to correct for microsaccades. It's one of the real beauties of this device is it has what's called projection artifact removal, which was available in the earlier iteration of the device, but which has been upgraded to really remove as much artifact as possible, making the actual evaluation and analysis more accurate. What really makes it stand out is how it performs the scans. The retina cube is 6.4 by 6.4 millimeters, which is a little bit above the ETDRS. But again, that's so that if there's a little bit of shift in fixation, we're still capturing the necessary part of the macula. And because it does that, there's the separation between one scan and another, one B scan and another, is 12.5 microns. The optic nerve is similar. It has a 6 by 6 millimeter cube scan, and the spacing is about 11.7 microns between them. Now, one would ask, what, these numbers are really, like, what difference does it make? Well, it makes a difference only that the competitors have or sometimes double in terms of the spacing. So that, again, this device actually has a greater resolution. Additionally, the way that it assesses the cup to disc is different than the previous device because it evaluates the Brooks membrane, and it goes 150 microns above it, and it's able to get a more, I would say, accurate or more consistent cup to disc that one might find when evaluating the cup to disc themselves. Finally, what's important is its repeatability and reproducibility. That's really very important because that goes to the heart of, can we trust this device when we see change over time? So its repeatability and reproducibility is about 0.7 microns. So if you see any change above that, and it's consistent, it's pretty much something to be concerned about. Other devices are almost twice that much or more than that. So that's really important. So this is a trend analysis, which again just shows you, gives you the opportunity to follow patients over time, and it looks at both you have the actual images of the optic nerve in terms of being able to look at the thickness and the ganglion cell. And again, clicking it allows you to really modify what you want to see, whether it's that circular grid or whether it's the the pixelated normative database. And on the bottom, you can actually see the actual numbers themselves, the averages, and that are being followed. For those who have an Avanti and are thinking of switching to the Solix, it also gives you, there is a feature that allows you to see the actual graph of the trend analysis. So it gives you the ability to somewhat compare, apples to apples in that sense. But the data is not transferred. This is new data because the technology is new. Now onwards to the to my case studies, because this is where what they say, the tire hits the road. So this is a patient who presented to me, and I'm just going to tell you a little bit about him, a little blurb. He's 62 years old, and he's telling me he hasn't been able to see right for a little while. And so you can see on the right side, you have this temporal hemifield defect, and on the left side, you have something that sort of is on both sides of it. There's something temporal, there's something on nasal as well. I'm going to show you how I went through evaluating this patient. And here we have the OCT of the RNFL. And we have a pixelated map on the right side which shows superior and also nasal RNFL loss, which you can also see in the actual peripapillary ring, which is averaged over there. And on the GCC side, we see this very interesting pattern of GCC loss is only on the nasal portion. On the left side, we have superiorly and inferiorly RNFL loss, and on the ganglion cell, we see a more dense loss nasally, but we also see it extending temporally. So what do we think this is? It's a large cellular and supracellular mass that's displacing the optic nerve and chiasm. And it's displacing it nasally. And it really, really fits what we're seeing on the OCT. There's an amazing correlation to the actual mass itself and what it's doing to the chiasm and the nerves and what we see on the OCT. Now, while this might sound like you see one or two of these a year or maybe never, what's the point? So there is actually an interesting learning and teaching point. If you do see, for instance, classical pattern of GCC loss nasally, binasal GCC loss, you should really stop, even in the absence of visual field loss, one should think about a paracellular mass. And if one wasn't able to order the imaging, one should refer this patient to either a neurologist or, more importantly, a neuro-ophthalmologist. This is another case of a patient I've been following for years. Before I was following her with the Optovue Avanti. And you can see that they're very large cups. But interestingly enough, really no damage. I mean, here, this is the actual pixelated map. So there is it's picking up some thinning supranasally, but there really isn't any damage or loss either on the RNFL or the ganglion cell complex. And these are the visual fields. And this is a patient that I have followed for umpteen years. Now, this is a patient who does not have glaucoma. This is actually a great patient also to look at with the OCTA, okay? Because the OCTA is also another tool to look for decreased vessel density at the optic nerve. And that's something one could technically follow over time. The OCTA actually is a very good tool to look for patients who have, or glaucoma suspects, to look for early disease. If anyone has questions at the end, I'm happy to answer them. Now, this is another interesting case. This is a right heminopsia. It's a 67-year-old patient that came to my office. He has a chronic posterior cerebral artery infarction, okay? And these are his visual fields. I mean, not visual fields, OCT. And what is interesting is that even when one has such posterior disease in terms of in the brain itself, meaning we're talking about the fact that it's really behind, and it's post geniculate ganglion. Even then, we are seeing retrograde, axonal retrograde degeneration. So this is something which is interesting to see, and you might see it in patients who have had strokes. Optic drusen is another useful entity to image with OCT. You can see the autofluorescence. You can see it on B-scan. And this is what the optic nerve drusen looks like on histopathology. You have these vessels on the surface, and you have these deep buried drusen with calcification. Now, I'm just going to show you what the images look like on, on OCT, on with the regular B scan. And what I actually like to do is I like to actually invert it and look at it almost like what I would be seeing on a histo slide. And you can actually see, because this is actually the angiography, you can see where the blood vessels are, because the blood vessels are marked by the red. And they're actually, it's eerily very similar to the slide. And then really, the drusen themselves are below that. The drusen are actually right over here, and they're actually, they're hypoechoic or echolucent, as opposed to what one sees on a B scan. Now, what's going to be important is how to differentiate patients who have pseudopapilledema, optic nerve drusen, versus papilledema. So the important thing to see here also is the fact that the Bruch's membrane actually, you can see, is angled downwards. And often that's the opposite in true papilledema. So one sees this pattern, one can be confident that this is a patient that does not have papilledema. Next case is normal tension glaucoma. This is a 65-year-old gentleman that I have been following for several years. And I'm just going to show you different OU reports to give you an idea of what we see. The first OU report is the actual thickness itself with the numbers in the actual circular grid with the pixelated map. But now you have the pixelated map on the GCC thickness, and you also have normative database flagging the portions of the grid, the circular grid, that are abnormal. And here we see what I wanted to show you before, is that this is a patient who I've been following in the past. So in this portion, we have the old OCT, the Avanti, and we have the new OCT, the Solix, over there. This patient actually was progressing, which already was picked up by the Avanti, but seems to have continued to progress. And the intervention I made was to perform an SLT. Moving on to papilledema. Papilledema, we have a patient over here in her 30s who I would say has moderate to severe papilledema. She had grade 4 to 5 discs in the Frisson scale. And here, again, I sometimes like to do this because it gives me, I like to flip the images because it allows me to see certain structures even better. And here you can actually see, that, well, certainly it's not tilting downwards, okay? It's, if anything, it's straightening, and it perhaps might be going up. When it goes up, it's certainly pathopathic mnemonic, but there are other signs as well. But it's something to look out for. And this is the actual thickness map without any normative database to analyze it. And you can actually just see, just by the colors themselves, how the papilledema is improving. This is similarly this is just a ONH GCC trend analysis, which also just shows you, well, first of all, it actually shows you the tracings themselves, and the tracings are really out of the what would be considered normal, and they're super normal, and you can see that over time they improve. So the intervention in this patient was she had a venous sinus stent performed by an interventional radiologist, and her papilledema resolved. This is an interesting case. This is a woman who was in her 70s, and she presented to me with what I initially thought was an ischemic optic neuropathy. If you look carefully, you can see that there is hemorrhage inferiorly, there's some swelling inferiorly, and my first thought was this was an ischemic optic neuropathy. But then I looked more closely, and what you can actually see here is you can see at the edge of the nasal edge of the optic nerve, you can see this traction pulling on the optic nerve. And this is what's actually causing that swelling. And ultimately, it seems that there is less traction, although you could somewhat still see that area, and the swelling actually did resolve. And this is another representation, but it's more a thickness map representation, the absolute thickness map. And what I'm showing here is another feature. You can check the box that says difference, and then instead of looking and trying to looking back and forth and looking for the absolute numbers themselves, you could just follow the trend and actually see what the difference is. And you can see at the end that the swelling has resolved inferiorly by 104 microns and 234 microns. This was an interesting case that presented to me, and I'm showing you the UBM first. This is a patient who had a sutured IOL and presented with decreased vision and was referred to me for evaluation. And this is the OCT of her optic nerve. You can really see the first OCT is really all over the place, and you can begin to see a pattern that's still very swollen that over time decreases. And this is just to show you that this imaging is showing you the actual difference or differential between the initial study and follow-up studies. This is what the macula looked like. So the macula, there was severe CME. This is just to show you a trend analysis of the retinal cube, which shows you that over time it decreased. And the same trend analysis, but now with the actual normative database. So you can see it's red. It's all red because it's severe, but it over time has improved. So what did I do? I mean, similarly, this is just another way of looking at it. You can see that the RNFL thickness has, and the GCC thickness the macula thickness has improved. What did I do? I put the patient on Prolensa and difluprednate, and over time, which took months, the patient, this resolved, and the patient's vision, came back to basically normal. And we didn't have to do any surgical intervention. Hypotenuse maculopathy is another entity that's very diagnosable with OCT, especially subtle cases. Oh, what happened there? Okay, it's still there. As a glaucoma surgeon, I cause a lot of hypotenuse maculopathy. Patients who have glaucoma surgery have decreased vision, and it's not obvious when looking at the macula. I mean, by the time it's obvious on the macula, their vision is really bad. But even then, it's helpful to have an objective tool to monitor either progression or improvement. And so this is a patient actually who had hypotenuse maculopathy. It resolved. If I'm not mistaken, I did laser suture lysis. The hypotenuse maculopathy returned, and ultimately, because the pressure came back up, it resolved. But it's a really very excellent way to actually monitor this. And here are just different representations. Here is here it is with the actual, with certain normative database that's average. And here is just your raster comparison. Raster imaging is something I've not really spoken about, but it really is an amazing way to really see evaluate the optic nerve and the retina in true high definition. I'm going to talk about a young lady who presented to my office with decreased vision, pain on eye movements. She was in her early 20s, and these are her visual fields. There's a central scotoma. You can see, again, on the actual disc cube multi-scans view that there's swelling. And this map is really helpful because sometimes it could be much more, it could be very subtle. And the only real sign is on the OCT. I neglected to show you what it looked like on the Optos, but on fundus photo, but it was actually more subtle. And you can actually see that it improved with time. Again, with the click, you can see that it improved with time, the swelling, but as the swelling resolved, we now have RNFL loss that's you see on a pixel map and ganglion cell complex loss. Interestingly enough, when the patient presented, she also already had some RNFL loss in the left eye. And disease like multiple sclerosis can often have asymptomatic RNFL loss. And that's actually another tool that OCT is a very useful tool in patients who have multiple sclerosis, even if they've never had an episode of optic neuritis. This is just showing you again another way to look at the data with that peripapillary ring. I think I'm up to my last case, really. This is an unfortunate case. A 14-year-old boy who has a sister who's a few years older, who's already blind, and presented with very mild swelling, okay? I'm just showing you really the grid to show this is actually a raster that just shows you mild swelling on both sides. And here you could actually see that as well. You can see swelling that improves. And here you can actually see that at the very end, it's all blue, the macula. And that's because this patient has severe ganglion cell loss. And this patient, when we did testing, had one of the genetic mutations for Leber's hereditary optic neuropathy. So in sum, I think the Solix is a device that can really help diagnose all forms, all types of ophthalmologic disease, and I find it incredibly useful. I'm open to questions.